Tinnitus is a very common problem that many people that live around us are experiencing. Essentially, I describe tinnitus as hearing a sound in your ears that basically other people don't hear. It could be a ringing sound, it could be a pulsing sound, it can be the sound of having a seashell over your ear or both ears. Where I get very concerned about tinnitus is where the sound is only on one side, and that would prompt us to have a much deeper evaluation. Tinnitus is actually more of a symptom than it is a diagnosis. Tinnitus can be secondary to anomalies in your blood sugar, to your blood electrolytes, from systemic issues like decrease in thyroid function. Tinnitus can also be secondary to problems with your ear. When you have high frequency sensory hearing loss, common in aging, common in people who've had exposure to loud sounds, tinnitus can be a secondary inner ear phenomenon. When you come into the clinic and that is your complaint, we take a very comprehensive history to try to understand, is this related to the ear or is this not related to the ear? And from that, it can determine where we go with further evaluation. On the hearing side, we get an audiogram to make sure that we know what your pure tone audiogram, so how you hear sound, and then how you process that sound into words. We call that speech discrimination. Once we evaluate that, we can determine, is it one-sided or is it on both sides? Tinnitus on one side is more concerning for some kind of neurological problem. You can have neurological issues with your brain. Tinnitus is common after strokes. It's common with metabolic anomalies. Most people who have tinnitus related to the ear have a high-frequency hearing loss, and they occur simultaneously. As with any form of hearing loss, we'd have to determine if you're a candidate for a hearing aid or some other form of hearing intervention. Very few options exist to actually treat the tinnitus specifically, particularly when it's related to the inner ear. So putting you in hearing aids, oftentimes by hearing the sounds you want to hear better, the tinnitus piece is de-emphasized by your brain. It's really a psychophysiologic response that actually turns the volume down. If there's obvious triggers you can identify, we try to eliminate those, whether those be in your diet, whether those be fatigue. Anything that makes you stressed out can turn tinnitus up. And that is a function of the limbic system, really your fight or flight mechanism being activated and amplifying the problem that you're having. There are, other than hearing devices, there's other forms of tinnitus management. Cognitive behavioral therapy is a big one. I always tell patients when they come in to talk to me about tinnitus that I'm going to be very specific in my questioning, and we're going to do some guided studies. Sometimes we add MRI scans to rule out problems with the brain and brainstem. Sometimes we'll do advanced hearing testing. And oftentimes I'll refer them to one of the tinnitus centers locally, and they have devices that are tinnitus maskers that ironically will bombard the ear with the frequency of tinnitus that you're having. They'll give that same sound, and over time your brain de-emphasizes it. That's the phenomenon of tinnitus masking. Once you start getting tinnitus, it's hard to turn it off. And I think the early care you provide to your ears, so your teens and your 20s and 30s, the better off you are as you get older. So tinnitus is frustrating. Oftentimes my job is to find a way for you to cope with it better. Nonetheless, it's important to rule out some of the other problems that can cause tinnitus that could indeed be treated.